everyone. We are ready for another student webinar. I'm glad you're here to join me. Don't forget, if you have any questions, you can post them in the chat. I already see Whitney saying hi. If you're watching us on Facebook or YouTube, again, don't forget that you can post questions there. Don't forget to like and subscribe if you're doing that. But when we get started today, we had 3 subjects that came through. One a little bit more lengthy, 2 that will be quicker that we'll go through. We'll save those other 2 for last. So let's jump in. Let's get started. This was a really kind of an interesting topic that came in. The student had asked, when do you use CPT code 20550 or 20552? What's the difference between the 2? And this was Linda that had sent this in. Well, what I did was I went and looked at both of them, just an indication when you have 2 codes that are so close to each other in numerical order, that's a giveaway that their descriptions are going to probably be very, very close. And that's what trips people up, is that the description is similar. And sometimes when you're looking at them to a student, they're thinking, well, what's actually the difference? And for me, when I looked at it, I thought, well, it's kind of blaring what the difference is. But then I realized, oh, wait a minute. You know, of course, if you don't have any background knowledge in what's being done, then I could see how it could be confusing. So let's look and see what those actual 2 codes are. 20550 is an injection, right? And so is 20552. Both of them are injections. So you're looking at the information. Now, I went ahead and put the guidelines up for 20550 because you want to be familiar with those, and I just wanted to show you and give you a heads up, because just in case I'm not able to bring over find a code, which I've got it open, and we'll see if it works for me tonight as I'm working off my hotspot. The main things are what I underlined. So for 20550, it is an injection, and it's a single injection. Now, compare the 2. When you look at 20552, it's a single injection as well, or, whereas 50 doesn't have or in there, but 52 does, or multiple trigger points. Okay, so let's go back to 20550. Injection, single tendon sheath or ligament, and it's called a aponeurosis. And this would be like for plantar fasciitis, if somebody has it, or the fascia of the plantar on the bottom of the foot, or tendon sheath. Okay, but when you look at 20552, it's a single injection or multiple trigger points. So now we need to decide what's a tendon sheath, you know, what's the ligaments and this aponeurosis, or what's trigger points. If you don't know what the difference are, then you're going to be lost, because ultimately they're in the same area when you're doing your bubble and highlighting of your manual. So let's look at the next slide. The tendon sheath. When you get a tendon sheath injection, what they're doing is they're just giving you temporary relief of pain. Okay, this pain is often done when somebody has been doing repetitive movements, which you'll notice in the other code for 20552, it's also a repetitive movement pain that comes along. Again, that's why it's in the same area. With CPT codes, remember, we are coding for what we're doing to the patient. Unlike when you get into similar codes for procedures like ICD-10 PCS, which is inpatient procedural codes, it's the outcome. So with this CPT, we're doing something to the patient. We're injecting them with something. And then we need to know where the location, where are we injecting? And the tendon sheath is a tendon that you've got tendons and ligaments that attach bone to muscle and muscle to muscle, okay? So a tendon is that fibrous tissue that connects the muscle and the bone together. When you look at them in the muscular system, or if you're looking at a procedure being done, unless you can see where it's being attached, you can't tell the difference. They look the same predominantly. They'll look kind of white and cord-like when you're looking. I'm here sitting here rubbing my hand underneath the screen, and you can't even see me doing it. So whenever you move your fingers, so look at your hand and move your fingers, and if you're able to, you can see the movement, which I don't know, you can see the movement of the bones, but those are also tendons and ligaments that are moving, articulating those little bones. So like this right here is probably a ligament, instead. See, oh man, look at that thing wiggle. That's interesting. Okay, so this again doesn't cure a problem. These injections are temporary relief, and often you have to have splinting, or you're also taking NSAIDs and things like that to help relieve the pain. This is the anatomy of the tendon sheath. So right here is the tendon itself. Then there's synovial fluid around the tendon, and around that there is a sheath of fibrous tissue that protects that tendon. Okay, so here's the bone. So here you're looking at my hand, and you're seeing that. Oh, let me get it in there. So where's that finger that was moving? So you can see that's very typical of. There's the line. There's actually a bone underneath there, but this is movable right there. So that would be like the tendon sheath, right? And then around, then there would be synovial fluid that protects that tendon, and then it lays on top of that bone to help it articulate, right, and move. It's very important that you understand there's synovial fluid, a synovial membrane that is also caught around that tendon. Whenever you've got anything that is repetitive movement, either whether it's part of your anatomy or if it's just out in nature, or think of a drill bit, it is going to cause friction. So that's what the synovial fluid does, is it stops the friction. If you've ever watched, let me think, my dad was a construction worker for a long time, and I remember with big heavy equipment, whenever they're drilling or they're doing anything that is metal on metal, they would always be spraying water on it. And I'm like, why are they spraying water on this? Because they're hot, because in the middle of the summer or something? No, it's to stop the friction from building up and it getting too hot, right? And that's what the synovial membrane and that synovial fluid does, is if you don't have that an adequate amount, it's going to heat up and cause damage. You've got synovial fluid all over your body, but it's especially found in joints and around tendons and ligaments. So on top of that, there's fascia, or fascia, however you want to say it, but that is also like tissue that helps keep things held together. So 2 layers that you need to be aware of: the synovial sheath and the fibrous tendon sheath that you see here. And then the bottom, the lighter color, that's actually the bone itself. Okay. Also, with this aponeurosis, and other people may say that differently, that that is kind of a white fibrous tissue that is at the end of the muscle when it connects. So look here, and you see that this area right here, this is the I think this is the abdominal muscle, but whenever you see muscle being drawn like that, Okay, there's the rectus abdominis, which is abdominal muscle, but all of this white stuff here is actually this aponeurosis, aponeurosis, or however you want to say it. Okay, so again, that can become inflamed as well. And that's where the second part of the information comes in for that first code, 20552 or 0. So we're working with injecting something into that tendon sheath or that tissue that connects the muscle. When we look at trigger points, a trigger point injection is called TPI. It is used to treat pain that is also caused by repetitive movement. I always think of this with athletes. And you can go out and you can Google how they do it, but you'll always notice because they'll put 2 fingers like this and then they'll inject between the 2 fingers. But why they're doing the 2 fingers is they're looking for a knot. Okay, they find the knot, they wiggle it around, and that muscle has literally contracted up and kind of spasmed into a knot. This is also a temporary relief treatment. It happens in different parts of the body, but I focused on the back because it gives you a really good example in the next graphic that I'm going to show you. When you can literally feel this knot up, and it'll be painful to the touch, but it'll almost feel like a knuckle underneath there. It can be bigger, but usually it's within the width of 2 fingers, and you'll see them, they'll push like this and they'll slide around, they'll find the knot, and then they'll inject right into the knot, and that will relax or help the muscle relax. Okay. Now, these are trigger points. This came from a slide share that I found off Google, off of ePain Assist, that fantastic slide procedure graphic on where these trigger points are found in the back. So these are common trigger point injection sites, and notice how they just kind of flail out, kind of like wings on each side of the spine on these major, these larger muscles. And again, this is a muscle disorder, and just think of these red dots as knots, the muscles that knot up, and again, they almost feel like a knuckle under the skin. They can be very hard, very painful, and they don't relax on their own. So you just inject them. And again, you can't get much better than this graphic of showing a needle in each one of these. Now, you're not going to do multiple ones like this. This is just showing the trigger point injection sites. Does that mean you wouldn't have more than one? Well, we know because of the code that we looked at that it said for 20552 single, or I believe it said multiple trigger points and 1 or 2 muscles. Okay, so this has laterality to it. So this, if you had one bilaterally here, one here and here on each side of, that's not the deltoid, I don't think. Muscles is not something I'm as knowledgeable as bones. At the upper apex of the scapula, I could tell you. So you might have 2 knots here. Well, that's 2 different trigger points, but it's also 2 different muscles because it's has laterality to it, a right and a left. Okay, so maybe the same muscle, but you might have one on 2 different sides, or maybe they have the muscle up here above the scapula and one on the other side down here low. Okay, it really depends what you've been doing repeatedly, but these muscles, these disorders usually happen with people that are athletes and have, again, repetitive movement or strain in one area. But it doesn't necessarily have to be an athlete. Maybe it's your job. Maybe it's something you do where you work in a factory and you're doing repetitive movement where you're moving boxes or something from one place to another, and you're sedentary, you know, and you're working one arm over and over again, and it literally spasms those muscles and makes the knots, and they can't be worked out just by, you know, like massaging them, or an NSAID, something to help relieve the inflammation. Okay, so any questions? Let me go back real quick. Any questions about the two different codes? Again, the difference in the two codes is location, right? One is doing the tendon sheath, and the other code, the 20552, is actually a trigger point injection, and you could use one or two. And you know, before we move on, let me just show you quickly what this looks like in the coding manual. Okay, go back again. So we've got the 20552, one or two muscles, a single or multiple trigger points. Okay, so if you have multiple trigger points and you have more than two muscles, then what are you going to do? You're going to look at your options, and it says here, single or multiple trigger points, 3 or more muscles. Those are your choices of the codes. Now, let's go back up here. 50 and 51, single tendon sheath. So tendon sheath, ligament, or this aponeurosis that attaches the bone, the muscle. You've got one here, single tendon sheath, or if you look at 20551, you have single tendon origin insertion. So again, those are different, and then trigger points, right? And again, I love Find a Code because they give us this description about, you know, an injured or overworked muscle. But look here, they have fantastic graphics. Now, these graphics that we can't use and like grab them and pull them in to our lectures because they are Decision Health and you have to pay for that. So, but we can share them live when we're doing this. So here we go. Hamstring muscle. Didn't think about that because I was talking about the back, but a trigger point, and see it shows a little circle here. And sometimes you have this muscle, and look, another common trigger point is over here. So these are two separate muscles here. There's the hamstring muscle, and then you've got a muscle that goes behind that as well. One or more trigger points in one or more muscles. So the detail is you need to pay attention to how many muscles for the trigger points. Whereas with the sheath, it's not the same. You don't have to do that. Okay. Next subject. Another question that had come in was CEUs and prospective employers. So the question that came was, can I take the CEU quizzes and include them in some type of portfolio to show prospective employers my willingness to learn new concepts? So what I wanted to do is I wanted to talk to you a little bit about CEUs. And I just made a little bullet point. Let's talk about what the CEUs are and what they do for you in and then talk about, you know, showing them to a potential employer. The thing about CEUs, which just means continuing education units, we used to call them credits, but it's actually units because it stands for a U. They're required by all types of professionals, whether you hold a certification or you hold licensure, you'll be required to carry CEUs. Sometimes they're in a year, or sometimes like the AAPC, it's every 2 years. It just depends what the credentialing company or the licensing organization requires. So continuing education units, whether you're a police officer, whether you are a doctor, or a nurse or a med tech, anything in the hospital, a phlebotomist, each one of them will require continuing education units. They want to show that you are continuing your education above and beyond having gotten your license or your credential. So that makes sense that, you know, a physician, you want to know that a physician is taking the time to get, you know, continuing education through the years. If they're up on the latest technology, the latest techniques in procedures that are being done, especially if they're a specialist like a neurologist or a cardiologist. We want to make sure that they know what's happening out in as our knowledge progresses, that they're on top of it, right? And now I didn't go in and look and see how many that a provider, an MD or a DO or a nurse practitioner, I didn't go and look and see how many is required every year for them. It's different for all of them, but even like a police officer, a fireman, they all have to take a test, a certification or a licensing exam. Even think of your driver's license. Now you think, I don't have to get CEUs for my driver's license. No, you don't. But you do have to, when your license expires, you do have to go in and have your eyes checked, right? Because you'll get a new license, but they actually check your eyes, or at least in Missouri they do. I don't know if they do that in Texas. If you change states, different states require that you do something to make sure that you have the ability to still drive. Before, I think our license was about every 2 years. You had every 2 to 4 years, but now it's even longer. Some are 7 years that you don't have to. But it's kind of like getting a continuing education. When a person is getting their learner's permit and then they have to take their driver's license, you know, they want to make sure that they know the rules before they get behind the wheel. You know, maybe not the best comparison. Again, if you can think of any other professionals that require continuing education units, let me know. You can put in the chat. Whitney is saying every 8 years in Tennessee, because I think that Missouri is every 7 years, maybe it's 8 years now. And when they first started doing that, and this is off topic, but it was all even if you were born in an even number year or an odd number year. So we thought that was kind of funny. Let's see. Oh, Whitney has also made a comment that said, you can still get CEUs from the AAPC magazine's monthly edition, even if it's a month or two later. That is correct. You can get CEUs online with them and go take their test, and those are free. For example, she said, I took the April quiz now and can still get a CEU, or you have to take it in a particular month. No, I don't believe you do. You can go back and I don't know if they'll let you do a previous year, but they have those online. You can go to their website, bring up the magazine, read the magazine, and then take the quiz all online. You don't even have to have it, which I've got mine. I don't know. I've still got on my desk. This is not the last one. I don't know if I can. Hold on just a second. My screen went blank with my picture, so I can. So this is one, and I actually have a stack on my desk. So that's the one that's just up at the top because I hadn't got to read that article yet. Again, you can get CEUs through that. Lots of places that you can get CEUs. Typically, most CEUs establish 1 unit per an hour of education. Now, this may not be the same for everybody, but predominantly for medical, it's 1 unit per 1 hour of education, and that's how the AAPC does it, and AHEMA, which is another credentialing organization that credentials coders. So when you see something that is valued at 3 CEUs, you know that it's a 3-hour lecture, or you'll be in there for 3 hours, right? And part of that, I think 20 minutes or maybe even 30 minutes can be open for questioning, Q&A. You know, they have guidelines specifically for that. But again, don't say that police officers are 1 unit for 1 hour of education. I could be wrong. You can do them live or online. Now, as you know, if you sat in any of our webinars like tonight, it's, you know, an hour, so you'll get at least one CEU for that. We have to get those pre-approved, and sometimes it takes time in the credentialing organization. You know, they're usually pretty timely, but of course, you submit the information or get pre-approval, et cetera, et cetera. But if you attend live, then you get the CEU and you don't have to take a quiz. Now that's through the AAPC. If you are just coming back and like using our CCO Club, we have over 100 CEUs in there. And what you would do is those are a recorded CEU. It's already been aired live. And so say there was a 2-hour lecture on cardiomyopathy and other cardiological disorders or something, and it's 2 hours, it's worth 2 CEUs. You would watch the 2-hour lecture, and then you would take a quiz at the end. So you got to take it online. You didn't have to be there in person. And the quiz validates that you understood or that you actually watched the presentation. And for the AAPC, everybody's a little bit different. They require 10 questions for every hour or for one CEU. So you know that if it's an hour-and-a-half lecture, you'll have 15 questions at the end that you need to answer that proves that you actually did watch the content. And if you watch it live, you have to be able to prove or validate before you're given it that you actually stayed and watched the lecture. Now you can also go to live presentations where you, like when you go to a conference. So I get to go to Washington, D.C. and Anaheim, California this year to do their regional conferences. I'm going to speak there. And they told me how long that they wanted me to speak. And then that would tell whoever is there physically how many CEUs that they can acquire from that. And so, you know, it works out perfectly. You can go to different events. You can go to your local AAPC chapter and sit in live. Each month that you go, you usually get at least one CEU for attending that. Let's see, certification organizations approve their CEUs. So we get asked a lot, and we've done talks before, and you can go to our YouTube and Facebook, or YouTube videos, and see the difference between CEUs for AHIMA and AAPC. We work with the AAPC, so we get approval for them. They've already approved our presentations because we're licensed through them, but AHIMA, we're not licensed through them. So therefore, if you have an AHIMA credential and you want to get CEUs from us, they would be approved on an individual basis. The certification organization has the right to say, yes, we'll take that CEU, or no, we won't. Okay, and we also work with PACOM, which is a medical management. Well, that works perfect because so much of what we do works with that credential. And so a lot of their members, we get approval for them to get CEUs, especially because so many people in medical management, they are coders as well, so it works out great. But they have the right to say, well, you know, that really doesn't apply to what we do as a certification, so we're not going to approve that for a CEU. HEMA is predominantly inpatient. So if it's about CPT, the lecture's all about CPT, well, that's not going to be something that they're willing to approve. Right. And you can't say, well, I sat in a lecture with CCO and I acquired 2 CEUs listening to Alicia on that brilliant lecture that she gave on cardiomyopathy. And I don't know why that's in my brain that I keep saying that. And you try to use that to get your continuing education units as a police officer, they're going to tell you no, because it isn't comparable, right? Prices vary. most of the time, and nowadays, since we have the ability to do so much remote and live remotely, prices have gone down. But if you go to a live presentation, physically go to a presentation, it usually costs a lot more. And that's because they have to pay for the overhead. They have to pay for the speaker. They have to pay usually for a place for the lecture to be provided. If they're going to feed you, they have to provide that, and so you could end up paying, $50 or $100 for a CEU, whereas if you're taking one online, of course, we're giving you one free, but it does cost to help provide these again. So, but prices do vary. You can get them anywhere from $10 to $100 for a CEU, depending on the specificity of the CEU, the complexity of the CEU itself. Now, let's see. Whitney has said. There's webinars that do CEUs that expired year earlier and it didn't apply to the present. They were so disappointed and the company wasted quite a bit of money. That happens, you're right. Whitney says, I have a question on submitting CEUs to the AAPC. Do you need to submit your certificate with each CEU in your tracker? Or is it not needed? I know you need to keep the certificates in case you ever get audited. You do not need to submit the certificate itself. I just happen to have on my desk, this is a from the Wichita, Kansas symposium I got to speak there, and the agenda that printed out, I don't know if you can see this, and these were the, I'm not going to save it to where you can see it, but those were the CEUs that I acquired, and then each one of your CEUs, when they're pre-approved, are giving an identification number, usually has letters and stuff. So I was pinning those in. I just happened to have that on the top of my desk, and that was from a year or so ago, as I'm trying to clean my desk off. So I went to a function, I got to lecture there, and it looks like the whole thing was worth 1, 2, 3, 4, I think it was 10, 1, 2, 3, 4, 5, 5.5 CEUs or 6 CEUs for that event. Of course, I didn't have to pay for the event because I was one of the speakers, but depending, the value of that was the content something that you wanted to sit in and learn from to get those CEUs, or was it just that you needed CEUs, you didn't care what the content was on? You have to think about that. So do you need to keep those certificates? You do not submit them. You just type in the number in your tracker and the date, and they've it's all automated. They know by that number that's alphanumeric who and where it's associated with. Okay, then you don't have to send in that. However, if I keep this form, I could keep this form, but this isn't the certificate form for that. So I need the actual certificates that I was given, right? Some people scan them into their computer so that you could just digitally send it to them if you're ever audited. But unless you're audited, you don't need to submit them to them. That's a good question. Yes, and AHIMA doesn't use, that's a good point, index numbers. There's submission process is a lot different, but they're a completely different organization. Time sensitive. So it is important to say that if you are going to go out on the web and look for CEUs, you want to make sure that the CEUs that you are taking are up to date. Now, we have over 100 of our CEUs, but any of our CEUs that were recorded, maybe the early part of the year, there's a time limit on them, and then we have to get pre-approval for them again. We have to go through the system again. They would get a new number, et cetera, et cetera. And when that transitions, you have to be on top of that. I mean, we have staff that has to take care of that to make sure that if somebody watches that video, that they know that the CEUs are not approved for that yet, because the AAPC hasn't gotten back with us to approve them, even though they were approved a month ago, right? They were still approved again. So it's a process that's all done on a date. So it's continually morphing and changing. Employers sometimes will pay for your CEUs if you ask. All you have to do is ask. Now, they, especially if you work for a facility, they'll set aside money to pay for CEUs. They usually will pay for CEUs for their providers. That's a perk for, you know, their providers, and they even their clinicians. They may do something in-house, do presentations and have lectures given for their clinicians that are worth CEUs because they know it's beneficial to them. They know they need them. Not so much for coders, right? Because that's such a minute portion of the staff. But when I worked in a facility, they did pay for the coders to have CEUs, but only a limited amount. You know, and usually they paid for them to go as a group, and they looked for something locally to get the most bang for your buck, in other words. When you go to conferences, regional conferences, national conferences, sometimes you'll be able to talk to people when you're networking, and they'll say, yeah, the company sent me. They paid for my conference, but they didn't pay for my trip or my hotel room. Yeah. And then you've got others that'll say, oh, yeah, every X amount of years I get, you know, I can go to the regional conference and they'll pay the bill. So, and another question, is there a limit on how many hours you would come and speak at a meeting? Well, for me, as a talker, I've done some very, very long ones before, but usually those were divided up in more than one day. So yeah, just we like to do that, especially if it's something that it's easy for us to travel to, especially if you will pay for our travel expenses. I did Wichita, and I actually stayed with one of their chapter officers, and so they paid for me to fly. I stayed with her at her place that night, and flew out the next day. That was great. So again, don't forget to ask your employers if, you know, every year or a future employer, do you help compensate for CEUs for this position? It's just a nice thing, a nice perk to ask for. Maria says, after entering my CEUs on an APC tracker, I basically waiting to submit them. How would I know if the CEUs are expired? It won't let, I don't think it will let you even put them in the queue if they're expired. It should flag it for you. I've done that before, and so, yeah, this one isn't going to work. It's expired. So, or if you get a character wrong when you're putting in the number for it, so you'll know right away. Okay. So, any other questions about CEUs before I jump? Okay. So, which credential after the CPC? So the question that had come in is, I'm about to finish my course and I already know I want to get another credential. How should I go about picking which one is right for me? Now, we've talked about this off and on throughout the years. We get this question a lot. And kudos to Lee for wanting to have not even passing their exam yet, and they're already thinking about getting another credential. So that's a great mindset, and we encourage at CCO you to get as many credentials as you can handle. There's pros and cons about getting credentials, so I've made a list of those and things you need to ask yourself. But again, one of the perks of having multiple credentials is it usually means your pay scale goes up. So we'll have to talk about that sometime, the pay scale and how that works. So these are the questions that I like to say that you need to ask yourself. When, as the educational director, I get asked this a lot. People will send me messages and say, what credential should I start with? What credential should I, look at next? What's my career path? What can I expect? If I want just one credential, is that going to limit me? Or, there's so many questions that can be asked. But when you're thinking about after the CPC, and the reason I say, and probably she said the CPC, is because that's the basic credential. That covers just about anything. You can work anywhere with a CPC that a physician works. Okay, so you, even though it's not an inpatient facility credential, it is accepted by a lot of facilities, right? So just know that wherever a provider is working, then you can get a job with a CPC. So ask yourself, when wanting to know which credential should I get next, do you want to work with dual organizations? So the AAPC carries the CPC and specialty credentials and inpatient credential now, but AHIMA is mostly known for inpatient. And they have a few other credentials, but they've been around since the 1920s, and it's always been classically inpatient that they are known for. So is that what you want to do? So the pros and cons of being dually certified, not multiple credentials, but dually certified with extra credentials, is that one, you have to pay out your dues to both. So you have to pay to be a member of the AAPC, and you have to pay to be a member of AHIMA, and you have to pay yearly. Now, that's another thing that you might ask your employer if they would pay, if they have an organizational membership that you can fall under so that you don't have to pay the fee every year. I know mine's was always due in October, so I made sure that that's when I always set my money aside to make sure that I could pay my dues into the AAPC. Again, that's something to think about. Do I want to get the well-known CCS credential, because that's a facility credential across the board that everybody recognizes, and it's a very high standard? Or do you want to have your CPC and get the AHIMA so that you are outpatient and inpatient high standard? Or now that the AAPC has a CIC credential for inpatient, do you want to stick with one organization, pay one dues, and then just get more CEUs? So it doesn't cost you in membership fee anymore to have multiple credentials with the AAPC. It does require you to have more CEUs. And you can go to the AAPC website and see. Luckily, a year or so ago, they finally put a cap on it, because people like our Chandra and even Skylar that are getting into double-digit credentials, it can get very expensive in just maintaining the CEUs and the specialty CEUs required for those credentials. But now they've capped it, so after you've gotten X amount of credentials, you don't have to keep getting more CEUs. So consider that. Do you want to get them all through the AAPC? Do you want to get them all through AHIMA? Do you want to get some from each? It really depends what your career path is. Let's see. It says, there was some talk at my local chapter meeting this week. Good that you're going to your local chapter meeting, that the CCC credential is one of the popular specialty credentials right now. I also heard the other day that the HCC coding is a good starting point for a CPC-I and the CCA credential. Do you agree with that? And yes, I do. I agree with all of that. That is very, very true. But the CRC is the credential for risk adjustment. And it's not required to do risk adjustment now. You do have to be credentialed, but and you can be a CPC-I, a newly credentialed, but the time will come when they'll require that you get the CRC. They're already talking about it, but it hasn't happened yet. You could be grandfathered in. Additional expenses. If you're going to have multiple certifications, you are going to be required to pay more, because you're going to have to get more CEUs. Now, you can go again to the AAPC, you can go to AHIMA as well. AHIMA, I'm not as familiar with. Several people with CCO have dual organization credentials. Skylar is one of them, Chandra is one of them, Laureen. Also, I am strictly AAPC at this point. I think I'm going to get the PAYCOM credential for practice management this year, but otherwise I only have the AAPC. So all of my CEUs are for one organization. But when you get into specialty credentials, then that means you have to get your mainstream credentials, or no, CEUs, but you also have to, you're required to get a certain amount of specialty CEUs for that particular specialty. Now, risk adjustment is not one of them. You don't need specialty ones. But if you're going to get, say, oncology, they're going to want you to get CEUs for oncology as well as for your other coding credentials. So that's an additional expense. Keep in mind that you want to plan for that, budget for it. Areas of interest. Okay, so now that you thought out 1 and 2, can I afford to get multiple credentials? What area of interest do I really like? So a person like Lee that has already gone through a course, about to finish the course and sit for the test, they already know, I would say, whether they preferred ICD or CPT. And that being said, even ICD-10 PCS, if that was something that they had gotten to get a taste of, if you were doing the CPC exam, then you're not going to touch ICD-10 PCS unless you're looking at it through maybe some of the lectures that we provide. So for me, I prefer ICD to CPT. Laureen had always in the past loved CPT, but once she got into ICD-10, I know she started really enjoying ICD-10. And so depending, let's say CPT has tripped your trigger, then you may want to, and especially E&M, there's E&M specialty credentials, and people that like CPT tend to also like auditing. Although auditing now is pretty much across the board. If you like to read documentation, stuff like that, then it doesn't matter if you like ICD or CPT. But E&M is definitely an area of interest, and some facilities that have clinics require that their coders get the E&M credential as well. If you like ICD, then you might want to go into inpatient and build on that and add ICD-10 PCS, or you might want to go into risk adjustment. And of course, I tell everybody to go into risk adjustment because I love it. And it's all diagnosis coding, only diagnosis coding, working with chronic conditions. So what's your area of interest? Do you like the disease process? An ICD, then risk adjustment is something that would work very well for you. If you don't care for that part, but you really enjoy the E&M, or maybe even specific types of surgery, or interventional radiology, whew, that can be very, very complex. I'm going to go in August and get some more education on that. Then by all means, the people that like CPT would go into that, or anything to do with like spine surgery, very detailed in CPT. That's where you start looking for your next credential. Then you need to ask yourself, am I going to be working remote or in-house? If you're going to be working remote, then that changes the credentials that you might be interested in, because risk adjustment is predominantly remote now. Even the facilities that are hiring people to work remote for them in risk adjustment are working remote. I was just at the San Angelo chapter this weekend, and one of the girls that had been one of my students when I taught at the college there, she is working remote for, I think, 2 different hospitals doing risk adjustment, which is, she absolutely loves it, and it just tickles me to see that she enjoys that so much. So again, remote and risk adjustment, that is more common, whereas inpatient, not necessarily. If you're going to get into inpatient, you may not find as many jobs in remote inpatient work. Although I have to say that even within the last 5 years, this has changed dramatically. Remote positions are much more common than they used to be. So think about that though. Do I want to work for a clinic system where I'm going to go into an office? That's going to change the credential that you might consider getting, versus, no, I want to work remote. and because my husband retired and we're traveling, and so I want to be able to, you know, leave at a moment's notice and take my work with me. You know, for me, working remote has been wonderful because we moved every year for the last practically 4 years, 5 years, you know, with my husband doing his education. So again, remote works great for me. As long as I can get internet and I have my laptop, I can work. So consider that, remote versus in-house, and what credential is going to work best for that. We're getting another question that said, let's see, is it really that beneficial to have specialty credentials? Again, where you work, that really plays into my fourth point on location, because if you want to get a specialty credential in cardiology and you don't live in an area that has cardiologists, then it's unless you can get a remote position for a cardiology network, and they're out there, don't get me wrong, they're out there, just not as likely, then it may be something to consider. I would say how you know if you want to get a specialty credential, and I'm not saying the CPC, the COC, the CRC, and even the CIC are not considered specialty credentials. Specialty credentials are oncology, obstetrics, interventional radiology, things like those are specialties. Okay, and you'll notice that they call them core credentials and specialty credentials. You'll notice that when you look at, for example, the AAPC website, right? So keep that in mind. Specialty credentials, if you have a job in that area, you get paid more. Okay, there was one time when I was testing, I went to take a test, and one of the proctors was a cardiology coder. She had one credential, and it was a specialty credential, and that's it. She'd worked for cardiologists for several years as their coder, and then she decided to get certified. She said she aced the exam because she was very experienced already in the specialty, but she chose never to get another credential because she didn't need it. Now, is she does she get paid very well? Yes, in cardiology, but she isn't going to be able to work pediatrics, you know, or you know, maybe inpatient coding, or, you know, et cetera, because she doesn't have that background. So she got paid very well for what she did with just a specialty credential, which doesn't always happen. Okay. For the most part, I would say that you're going to have a core credential, and then you're going to add specialties to that, as either one, you're requested to because they want you to be educated in that area because you're going to be doing work for them, or it's something that you're very interested in, you're pursuing a career in that specialty. Okay, so location. Location makes a huge difference in your pay scale. So does it pay to have a specialty credential when there are no remote jobs and you work, there is, the closest hospital is 60 miles away, and it's a small rural hospital with a cardiologist, but they don't have a neurologist, and they probably have an orthopedist, you know, cardiology and orthopedics, but that's it, you know, and that they have a small ER, you know. If it doesn't have a remote job, then you know, the chances of you getting a job with a cardiology coding specialty may be very minute because they probably already have a coder, and they don't need another one. You know, so think about that. Also, it is true that locationally, if you're not working remote and you live in an area like Houston, they'll eat up specialties all day long because there is so many hospitals, different kinds of facilities and things that, you know, yes, specialties will benefit you if you live in a metropolis type area, if you live in a bigger city. Now, For my area, I guess the town that we're in now is a little over 30,000, but the town next to them, which is literally a hop, skip, and a jump away, is you know, over 100,000. And they got a VA hospital, and they've got two other hospitals, large hospitals, and then we're very close to Austin, which is full of hospitals. Now, you wouldn't necessarily drive to Austin because it's 45 minutes from where I live, but again, specialty credentials in my area are a perk, you know, so that would change your pay scale. Are there facilities in your area? You know, if there's not, then again, unless you work remote, additional credentials, you're going to need to think about that. Do you need the COC if there's no outpatient facilities by you? Probably not. You know, now, you know, is there a gosh, I'm trying to think of but the COC is a core credential. But I just want to mention too, a little heads up, if you have the CPC, you could probably immediately go test for the COC as well. The credentials are very similar. One with just a little bit more education, then you can probably ace the COC as well. And that's two credentials that when people are thinking that they want to get another credential, I lead them towards that. Or if they really like ICD, I tell them, you know, hey, CRC is very, very hot. You might want to get that. Working remote, everybody wants to work remote, but there's a lot of pros and cons to working remote. A lot of times remote work, you are you do contract work, so that messes with your taxes. And you have to have a designated area to work, because if you don't, it's a pain. If you saw my desk right now, you know, I don't need my desk to be in an area where I'm playing Jenga with a stacks of papers and the children are, you know, going to be able to walk by and knock things over. So you need you can't work off the dining room table and work remote. So keep that in mind. Memphis, yeah, Memphis would be a large area that would absolutely be a good place to have specialty credentials. Houston is 2.5 hours away from me, I think. But I've known for years that if you look at the top 3 cities in the United States, Houston is number 3. So in pay scale. I can't remember now. I can't remember what the 2, I was thinking Boston was one of the top 2. I haven't looked in a while, but the reason Houston stood out to me was because it is, I lived in Texas for so long. So I was like, oh, Texas, Houston, right? So Memphis is also a big one. Anywhere where people retire to, you know, Florida, they pay out real well too. So any other questions about what credential to get after the CPC? There's so many that you can get. If you aren't sure, say, I want to talk to somebody about it. I want to kind of play some things out in my head, ask some questions. Feel free to do that. Jump into our CCO Club and ask. Say, this is my, you know, this is where I live. This is the geographic location, as well as what facilities around me. This is what my interests are. You know, what are you thinking would be maybe another credential for me to look into, not to go get, but, you know, should I look at, you know, XYZ, or what's out there that I'm not aware of? So again, we would love to answer that question, and you can send us a message on our CCO Club to do that. Okay, I think that's it. Any other questions? I didn't even pay attention to the time. Wow, we did pretty good. It's like 2 minutes for the hour. Usually in the past, we used to do about 1.5 hours, but I think an hour is pretty good for student webinars. We had a lot of good feedback. Thank you, you guys, for sending messages. If we don't have any more questions, then I'll let you go. But keep in mind that we're just a few keystrokes away at the CCO Club, and that's the fastest place to get your questions answered. Okay. All right. Have a great rest of your day.